Thank you all for coming tonight. As you know, this is our last meeting before the conference, which is on Tuesday. We have a variety of really good speakers, but one of the things that happened in our design and planning of the conference, at the time we did this, India was doing quite well. We hadn't had it as a country to invite to our conference. Of course, we only had 7 countries to invite. But nevertheless, they went through a surge and I think learned a lot from their experiences. And also the major variant, which we're now concerned about in the United States, which is the B1617 or Delta variant, originated in the country. And it's now expanding quite rapidly in the United States, becoming on track to become the dominant strain. So because of that, I've asked Dr. Vineeta Gupta, who's a maternal and child health physician and also an international human rights lawyer, to talk about the situation in India. And she is really nationally renowned. She's the director and action secretariat of the Action Global Health Advocacy Partnership. We're very privileged to have her here. And anything we can do as a nation to support other countries is something that I think needs to be encouraged. We really do need to have this controlled by a worldwide coordinated effort. So with that short introduction, let me turn the microphone over to Dr. Gupta.
Thank you. Thank you so much, Kevin, and thank you everybody for giving me this opportunity. So as you mentioned, Kevin, in the preface to this conversation, that India's situation in India really escalated very fast. And the first wave was controlled very well. So India was not on the horizon for disaster to watch, because it was like something that people were amazed that how it was controlled in India, and took it blindsided the global community as well as Indian health community. So let me start by sharing how it has been like in India. It's the India COVID SOS organization is a volunteer organization, and it came as a loose structure when we saw that what was going on in India, and some of us took initiative to rally diaspora, Indian diaspora in the US, and then it just grew and grew. And people were very passionate, and I'll talk a little bit in the end who we are and how we came together. So the situation was really dire. We were working around, our volunteers were working around the clock, getting all these phone calls, WhatsApp messages. It was a dire shortage of medicine, oxygen supply, bed spaces, funeral services. People were WhatsApping our volunteers saying, hey, do you know a 57-year-old man with this symptom? Do you know anybody who can get us an oxygen bed? So these kind of messages we were getting, and our volunteers trying to hook them up with the local volunteers to find beds, or financial help with funerals, or other sort of one-on-one kind of help that was happening. Mental health repercussions for the physicians as well as for the community at large were huge. It was crazy. One of the friends I was talking to, they said we have converted our parking lot as a funeral space. And India, as you know, the majority of the population follows cremation. And so there were pyres lit in the parking lot of the apartment building's front yard. So those kind of, it just threw everybody off balance. Mental health for, as I mentioned, for the community, for health workers, for family members were just off the roof. And schools were closed at one point. And midday meal, it's a program that's implemented in most of the public schools in India. The midday meal is usually the only nutritious food that kids get from lower socioeconomic population. That was totally shut down. So hunger in children were very, very large problem, as well as it was in larger community, migration population who were not getting their livelihood, so they were migrating to their homeland, and they also carried COVID with them. It was just a disaster situation. 70% of the respondents from a survey conducted in India during the lockdown reported food distress. And there was a big conversation going on between global health community and larger community on humane stay at home. How do we ensure that people, when they are staying at home, do have access to food and basic needs of their families and themselves? So I put together some pictures to go through what was it when it hit India at the most initial level. So the pyres were lit everywhere. Bodies were left around the rivers or ponds to be floated in the water. People didn't have money for wood, so half of the wood was purchased, them needed for the pyre. So there were burned bodies all around the place. Migration was really hit. Internal migration, so people were going back home. Crowding, extreme crowding. It's really, I don't want to say word helped because it's positive connotation. It just spread the COVID across the country. And as I mentioned, midday meal scheme closed down and kids were just hungry and lack of nutrition. They were facing extreme challenge. The ASHA workers are some of the basic healthcare workers. So they're very poorly paid. They were thrown in the middle of this episode from this pandemic, and they were doing their own job as providing the community support on MNCH, maternal and child health, newborn health, and COVID was on top of it. There was not enough resources and time to even train them for COVID. So they just took over it, and they're very poorly paid. Medical students from third year onwards were drawn into this without proper training, which is a disaster situation for both ends. For the students themselves, given this heavy load of responsibility without training, and also for the patients who were treated with inadequate training. And also then I mentioned a little bit on the mental health turmoil for the health providers. One of the doctors who shared their challenge on our meetings on COVID India COVID SOS meetings, she was sharing, she said, people are so stressed with need for the money and hospitalization that sometimes the patients are asking to take off their mask because it was so expensive and they didn't want to drown their family into the debt situation after they're gone. And they saw that, okay, I'm really sick. What do? I choose to die and leave my family with a debt or without a debt, or I die anyway and leave my family destined to doom. So that kind of, and she was crying. And we carry, as a diaspora, we carry this weight of these stories and helplessness. And we were just, all of us, trying to scramble through and trying to do whatever we could. So these are some of the tragic stories that emerged from there. Vaccination, when the vaccination started to flow in, the appointments were made, but vaccines were not available to people. People were put in the tree with the drips. And there was another video that was shared with us on our volunteer portal, the coverage that some volunteers from religious organizations were helping with the oxygen. So they're using the industrial oxygen for people, and necessarily not by the trained professionals, and there's a tank on the roadside. It's just mind-blowingly stressful situation with no good alternative. So this is kind of talking about Indian diaspora, how we were helplessly watching and trying to do something about the situation. Many doctors were lost they lost their lives to addressing that at the front line without having enough equipment or preparedness or trainings to deal with it. It's, as you know, it's spreading to Bangladesh, Nepal, Indonesia. It's just off the charts how it is spreading from India. And it's a tragedy that global community and so many barriers were there for people to help the situation in India. And then we are behind the COVID pandemic by miles, right? So it's just spreading to different situations we could have curbed in India itself if we could get our ducks in a row as a global community, as a community, even domestically in countries. So now what's happening is that when we look at the data, first of all, I want to caution people to look at the data with a pinch of salt. Data collection is a challenge anywhere in we have seen in the US how we fudged the numbers here. And India, I practiced 10 years for in a public health sector, and absolutely every team meeting, every district level meeting, state level meeting, the numbers were fudged. And if people like me stood up, that was seen as a problem, stood up to not agree to fudge the data. And when we look at the data, sometimes it numbs when it becomes hundreds and thousands and millions. It becomes numb to not think of numbers as a family, as a story of an individual, and how it is impacting the community. And believe me, in our meeting that we had during the height of the pandemic, we had every day from 6 p.m., different kind of meetings of the volunteers until past midnight. And there are stories after stories, what's happening there through our portal and Slack that people were sharing. So what is its situation now? So there is a little bit of control at the urban level. It's shifting to the urban and the peri-urban, from urban to peri-urban and rural areas. And it's not filtering, the stories are not filtering as they were filtering from the urban area to the global stage. So we are hearing it less and less. It peaked at May 8th, and there were 403,000 active COVID patients. And I cannot emphasize enough that this number is so underreported. Infections, as I mentioned, they're decreasing at certain level, but what we're hearing is that there are different type of challenges that are emerging. Nutrition is one big one, vaccine equity is another one, livelihood is another one, women impact on women is another one. And I'll talk a little bit more later. I want to share more anecdotal and what we are hearing from our ears on the ground, then going through number. I'm happy to share this PowerPoint afterwards, and you can look at some of the numbers that are there. So health disparities, as we know, always existed. This pandemic has exposed health disparities at the global level. And of course, in India, it's just such a wide divide between the resourceful and the marginalized. And it just increased multifold. We have moved way back into our struggle to get health equity, moving to better place. Malnutrition is just affecting children, maternal health, newborn health, stillbirths number have increased, and it's immunization for the children. Routine immunization has been very deeply affected. Social conditions worsen, mental health issues have been a very big issue right now. Estimated 100 million people have fallen back into poverty because of this pandemic. Health workforce is stretched, and a lot of things that they were have suffered because of them mobilized towards COVID-19. Antibiotic misuse, I'm sure you are reading through the newspapers in the US as well, how the antibiotic misuse has resulted in fungal infections and others, and people foresee it becoming even bigger problem for antibiotic resistant bacterial infections. And we are at the India COVID SOS, we have come up with some guidelines and some job aids that we are sharing to mitigate the antibiotic misuse by the health workforce, formal and informal, both. So what we think that could help in this situation, some things at the Indian level. Transparency and accountability has been totally missing. Data collection and sharing was very restricted. So the response could not be based on evidence and facts. And it could not be targeted and customized, especially in a low resource setting. Foreign support restrictions have been on the increase for a decade now, but right now they were so detrimental to the help that the global community was mobilizing, whether it was in direct amount, financial help, or was it in terms of sharing equipment, PPE, all those things were affected by the restrictions on the foreign support. Technical assistance, for example, a lot of doctors here at the top level are engaged with our volunteer effort. We were not able to run direct telemedicine support or support the already existing telemedicine effort at the ground because some of us have run out of our licenses in India. Some of us maintain it, some of us haven't. So we are not allowed to actually directly provide those assistance. So that really created a barrier for available help and needed help, and these restrictions were sitting in the middle. Humane shelter at home, how to come up with the Indian government to have policies that would support people who are restricted in hold to mitigate as a mitigation strategy. Universal masking, district level intervention and focusing on the PHC, strengthening the PHC to help mitigate the deaths of the disease, both maternal and child health care and nutrition as well. If the midday schools or midday meals are not available, then what to do to provide nutrition to the children at home. So these are some of the things that we feel the Indian government can do. And again, I put a point there that these are very few things I've put together as top line that we are working on. So multilateral mechanisms, Gavi with CEPI and WHO, we are asking them to prioritize in India in Act A essential health pillars and COVAX activities to relax the restrictions to access those resources. Now, it is very important that this help is provided promptly and urgently. One thing is that it's the right thing to do. Second thing is that it's so much needed to get ahead of the pandemic in India so that originally it could be controlled. And we as a global community failed that step needed. So it's already spreading everywhere and resources are stretching even thinner. As part of the Gavi 5.0, preventing the backsliding of the routine immunization in India. Global Fund leveraging the resources to address the surge for treatment, diagnostics, and surveillance and support bi-directional testing of COVID-19 and TB. Global Fund to also scale up and distribution of COVID-19 treatment and diagnostics, PPE to protect health workers. World Bank to expedite the disbursements of the allocated funds for India. And then there are some that US has done recently, as Kevin, you were mentioning before, as the recent step that US government has taken. Very thankful for Biden administration on the vaccine issue, on the TRIPS relaxation, but it's far less than what we need. Despite the TRIPS relaxation that US government has already announced, it's not affecting the actual availability of the vaccine at the need level. So sharing all from top to bottom COVID-related technology to manufacture, distribute, and utilize. And yesterday we had this conversation in our meeting of the volunteers. Canada has surplus vaccine, but they cannot be, and India needs it. But as we felt helpless, we could not facilitate that space to get that vaccine to India because of the restrictions that are along with those vaccines from the manufacturers. So if they're loaned, there was some restriction. If they're loaned, then their their indemnity does not apply, but otherwise that applies. So it makes it very difficult for Canada to utilize the near expiry vaccine for getting it to India where it is needed. And global leverage, US has so much power of its word, of its leadership. They can leverage the accelerate funding and transfer of medical supplies to India. Technical assistance, medical and public health infrastructure development assistance to India, and diplomacy to increase transparency in data and reporting on COVID-19 cases and deaths and breakthrough infections and variants. And yesterday there was a news on MSNBC and other mainstream media that how we are detecting here the variant that's linked to India COVID-19 crisis. So it's everybody saw it coming, but the effort was way much shorter and to get ahead of it. So these are some of the things that we as a group are recommending. And India COVID SOS, as I mentioned, it's a 100% volunteer effort, came through as a response to India. It's our homeland, which is in pain, and we cannot disconnect ourselves from that pain. Directly, our families are affected. We are affected as people, as a community that's linked to our homeland. So all these things mobilized, and now it has grown bigger. We have a lot of global community part of this initiative. Nepal, we hear activists from policy advocacy and providers and technical and scientific community from Nepal, Bangladesh join our conversations as well. As you see the breakdown on who makes India COVID SOS and volunteers. So we are doing our best. We are restricted by so many barriers from the US and the global mechanisms and Indian government, and we are finding creative ways to help. So that is, I apologize if I rushed too fast, but I thought I'll keep some time for our conversation and the question and answer or thoughts that you might have.